Hi everyone. So the purpose of this video is to talk about the external ventricular drain. This is a drain that would be inserted into the patient's ventricle. For this video, you should review the anatomy of the human brain, the ventricles, as well as the CSF, or the cerebral spinal fluid, where it circulates in the brain and as well as in the spine. Just as a reminder, the cerebral spinal fluid circulates in the ventricles as well as in the subarachnoid space in the brain. So this system is the external ventricular drainage system, and an external ventricular drain attaches to an actual drain that is in the head of the patient, usually sitting in either a lateral or a third ventricle in the brain. The reason for inserting an external ventricular drain is usually to either monitor intracranial pressure, or ICP, or to drain CSF. The reasons why we might want to do that is usually in cases where a patient has a severe intracranial bleed, where the intracranial pressure rises and we need to relieve some of that pressure by draining the CSF, or in cases of severe hydrocephalus where again the ICP is increased. So a neurosurgeon would insert a drain into a patient's ventricle. Usually it's done through a burr hole on the patient's frontal lobe. And then this type of a drain would be attached to it and it would sit right there. The dressing on this drain will always be sterile and occlusive. And the procedure for manipulating this drain always has to follow aseptic technique, because obviously if we are accessing something inside of the cerebral of the brain, we have to stay very sterile. Let's look at the components of the system. This is the external ventricular drain. It will come assembled like this. I'm just going to show you some of the components of the system. So when you take it out of the box, this is what you will see. Here you have a burette or a drip chamber, and you also have a collection bag. This is where, if you're draining the cerebrospinal fluid, this is where it will accumulate, and this burette allows you to measure exactly how much CSF has drained, and we usually should record this measurement every hour or 2 hours if it's being drained continuously. It could also drain intermittently, done by you, if there is a specific ICP prescribed by the surgeon. Once the burette has filled in, or once you have taken your reading at 1 hour or 2 hour mark, you can always open the stopcock to drain the CSF that's in the burette into the collection bag. Okay, so here you will also notice that there's a different gradation meter for different types of drains that exist. So the drain can actually be used for lumbar drainage. We are still draining CSF because CSF circulates in the subarachnoid space around the spine as well, or it can be used for ventricular drainage. Okay, you will also notice that here it's centimeters of water, and you can also have ventricular drainage in millimeters mercury. So all of these measures you can change when you set up your system. Normally, when we're setting up our EVD for ventricular CSF drainage, we will set it up to ventricular millimeters mercury. Okay, so I'm going to keep it there. Then if you look here, you have ventricular drainage and lumbar drainage slots, and this is where you will attach your tubing and your transducer. As a reminder, a transducer is your fluid air interface that will actually allow you to measure intracranial pressure. So it will be attached here for ventricular drainage or here for lumbar drainage. So I'm going to attach my clip, and then we're going to set up the system. As I'm doing this, a reminder that when you're operating the system, you have to remain sterile. I'm not currently using gloves because this is a demo system, but you would normally use gloves. Okay, so how do you put this up? You will notice that there is a string here and the little black clip moves up and down to allow you to adjust for height. And there's a button that you can push on it to adjust the height of the cord. So I can hang it up at any height that is prescribed by the neurosurgery team and readjust the cord like this. As a security mechanism, we also have a clip here, and I will also tighten the clip. So this way, my system is held up in two places, because what we don't want to happen is we don't want this to fall and disconnect from the patient, or we don't want this to fall and the CSF would start draining into the chamber because of the gravity. So once I've connected my system, there are different settings that we can look at. Your burette or your drip chamber can be set at different levels depending on how much drainage your CSF, your neurology team wants. So I can move this up and down. What's important is when you move it, you need to unscrew this little cap and you need to stabilize the collection chamber with your hands, because otherwise it's just going to drop. Normally, ICP values are from 0 to 15 millimeters mercury, and the neurology team will tell you where to start your drainage chamber. For example, if you don't want your ICP to go over 15, you will set this chamber here, and once the ICP in the brain, in the ventricles, reaches 15 millimeters mercury or higher, you will see some drainage here. Alternatively, they might tell you to start it at 5, so you would start it here, and then you would start draining cerebrospinal fluid as soon as ICP in the brain reaches 5. Okay, this is an absolute 0, so when it's here, you're not likely to see any drainage, because this is also the atmospheric pressure. Now, the other thing that you need to do with the system is you need to level it to the patient. And normally we try to level it to the third ventricle, which is approximately at the tragus of the ear, so the external auditory meatus, and the tragus is this little piece on the ear. How do you level it? You need your transducer. The transducer will be attached here, like so. And this black dot on the transducer is the part of the system that you level to your patient's tragus. So different hospitals and different institutions will have different ways to level this. Some of them will have a little laser pointer aligned on their EVD, and you can move it up and down to shine it to the patient's tragus. If not, I can move the system myself. So let's say if I look at my patient now, I'm way too high. So I will have to lower my system until my little laser pointer is shining towards the external auditory meatus or the tragus. I can also raise the bed so that the patient is more aligned with my transducer. Once the system is leveled, you can start measuring your ICP. Some other parts of the system that are useful for you to know are all the stopcocks here and here, and there is usually an additional stopcock that we put right over here between the transducer and the system itself, and you will see why. Okay. So this is your transducer. This will connect to the monitor so that we can measure our ICP. Okay, this is a 3-way stopcock, and right now it is open to the system, so the transducer can sense the pressure inside of the cranium. This is open, which should never happen. So when I am putting this on with my sterile aseptic technique, I would always put a non-vented cap on it, like so. Okay, because again, we are trying to keep our system sterile inside. This part of the system goes directly into the patient's ventricle, and you will see that it's very clearly labeled CSF Access. So when you see this is not a port for injection. Nothing should ever go into the patient's ventricle unless in very, very special circumstances an antibiotic administration is prescribed or some sort of an anti-clotting agent. This is not something that you would be doing on your own. So this should never be accessed other than for CSF sampling. So, and that would rest over here. Okay, if you look at this stopcock, right now it's close to the transducer, so it's actually not sensing any pressure. So if I want to keep measuring my intracranial pressure, this needs to be open. So I'm going to open it to the system and to the transducer. Okay, so if I want to drain CSF, all of this needs to be open because remember, this leads directly into the ventricle and this is how the CSF will drain. Okay. So now I have my system set up to be draining CSF continuously. One important thing to remember is that if your patient is on continuous CSF drainage, they should not be left unattended, and you should be checking the amount of CSF drained in this chamber every 1 to 2 hours. Now, another thing to note is that if your system is open to CSF drainage as well as to measure intracranial pressure, what's going to happen is the intracranial pressure is going to be affected by the pressure of the fluid draining into this chamber. So your ICP reading is actually not going to be correct. If you need to measure your intracranial pressure while your patient is on continuous CSF drainage, you need to temporarily stop the drainage and then measure your ICP. So what I would do, if I look at my stopcocks, this one is open to my transducer because this little wing means closed, and there should be a sterile cap here. This one is open to everything, so that means that the CSF is able to drain into my collection chamber. If I want to measure a real value for my intracranial pressure, I need to close this stopcock to my patient so that the CSF is not draining. So what I'm going to do is I'm going to do this. So right now, the CSF can still come here. It does not drain into the chamber, but my transducer can still sense it. Once I am done measuring my ICP, because I will be looking at the monitor and reading out the ICP value and recording it in the patient's chart, I can reopen the system again so that it's open 3 ways. Now, this is just one way to configure your system for ICP monitoring. Another way to do this is, again, I would be sterile when I'm setting up my system. I would not connect my transducer here, but instead I would just keep my sterile, non-vented cap here. I will take extra pressure tubing that comes in a sterile package, and I can connect the pressure tubing directly to where my ventricular drain sits. So this is where my CSF measurement line originates. I can take off, because this is a 3-way stopcock, I can take off this cap. I can connect my pressure tubing here and then connect it directly to the transducer. Of course, all of this would be primed with sterile saline with no preservatives. Okay, this would connect to the monitor, and now this sits in the patient's, well, a drain connected here sits in the patient's ventricle, and I'm measuring my intracranial pressure with this transducer, and it is a lot easier for me to level the transducer to the patient's tragus. Sometimes this transducer will be taped directly to the patient. Sometimes the transducer will be taped to the monitoring system like so, but this is just one of the ways to set this up. You are still able to drain CSF and measure the intracranial pressure.